Hi there. This is Chapter 13, Experiencing Loss. And again, the disclosure statement, I don't own this material. Under fair use, I am providing content only for my nursing students. And all content within is only for educational purposes for nursing students and does not provide medical advice. So, what is loss? Loss can be seen as many different things. So it could be the loss of a job, the loss of a loved one, the loss of a pet, whatever. So loss is an undesired change or removal of a valued object, person, or situation. Categories of loss. Some categories include actual, perceived, physical, psychological, external, environmental, or loss of a significant relationship. So physical loss might be injuries, amputation, organ removal, like a hysterectomy, loss of functioning, like paralysis during a stroke. So whatever it is a lack of something that was valued. So clicker check. The student nurse has earned A's in all of her prerequisite courses. For the first exam in the nursing course, they earned a D and now feels like they may not be smart enough to become a nurse. What type of loss is the student experiencing? Actual, external, physical, or perceived loss? Okay, so it's considered a perceived loss because they're perceiving themselves as not being smart. That smartness would be an internal. So unless they choose to share their grade with others, it cannot be seen, so it's internal to the person. But it is also not a physical loss because they didn't lose any smartness. Smartness is a determination that the person has made. Okay, grief. Grief is a physical, psychological, or spiritual response to a loss. And that might be mourning, which is action associated with grief, or bereavement, which is mourning in an adjustment time following a loss. Some major theorists that have to do a lot with this includes Engel, Bowlby, Rando, Warden, Kubler-Ross, Strobe and Strutt, Klaus, Silverman and Nickman, and Niemeyer. I would tell you the only one I've ever seen used on an NCLEX test is Kubler-Ross. I would know Kubler-Ross's stages back and forth. Okay, so factors affecting grief. The significance of the loss. A support system. Unresolved conflict, and circumstances of the loss. So if you think about the significance of the loss, if you lost $1, would it kill you? Would you think, oh my gosh, I've got to go after that $1? Probably not. Your support system. So we always ask about the support system because we want to make sure that they have a support system around them that they can talk to and they can talk this over with. The bigger the support system, the better. Someone will be able to see that this person is having trouble. Okay. Unresolved conflict. If there was conflict in that relationship, that might really change how long it takes to get over that grief. So if you had a fight with your dad and he died the next day, there might be some unresolved conflict in that. Most people, when they're on their deathbed, are trying to resolve grief and conflict that has occurred with their substantial relationships. And then the circumstances of the loss, that really affects how much you grieve about it, because the circumstances surrounding the loss might be different. So suicide versus cancer, a child versus an adult, an older adult versus a younger adult. There's circumstances around that loss that affects the grief that someone would feel. Previous or multiple losses. So the more loss that that person has had, sometimes it's easier for them because they've had experience with it. Spiritual, cultural beliefs and practices. So the more spiritual a person is, usually they have a lot of support systems that can help them get through that bad period of time. The timeliness of the death and the developmental stage of the bereaved. So obviously if it's a child and a child doesn't understand death, they may not have as big of a deal to get over it as an adult. So it just depends on the developmental stage. Uncomplicated, a normal grief process, or a dysfunctional grief process. So dysfunctional or complicated could mean chronic grief, masked grief, or even delayed grief. So if that person was so busy making arrangements for the funeral and everything, it might be a delayed grief reaction. Disenfranchised. Sometimes people feel disenfranchised by the whole grief process. And then anticipatory grief. Sometimes we talk about this in nursing with patients that are going to come in for surgery. If they know that they're losing their leg, if they know that they're going to have a colostomy. We deal a lot with patients with anticipatory grief. The loss of a breast, the loss of hair with cancer patients, things like that. Okay, clicker check. A young woman's fiance died in a car accident 1 month prior to their wedding day. Since his death, she has become sexually promiscuous. Which type of grief, if any, is the woman displaying? Chronic, disenfranchised, masked, or no grief? So what is she doing? Question. So she is being masked. So mask means maladaptive behavior to mask her grief. So there's only been a short period of time since her fiance's death, so she's expressing her grief through her maladaptive behavior, her sexual promiscuous behavior. How is death defined? So there's different ways that death is defined. There's higher brain death, there's the Uniform Law of Commission, and then a Uniform Determination of Death Act. So death usually means lack of higher brain functioning. Coma, a persistent vegetative state. So a coma, the person is in a coma, and a persistent vegetative state means that there is no brain activity shown, but rather that we're keeping them alive in a vegetative state. The physiologic stages of dying, 1 to 3 months prior to death, then 1 to 2 weeks prior to death, the days and hours prior to death, and the moments prior to death. So there's things that occur during these stages. So 1 to 3 months prior to death, the person begins to withdraw from the world and people. Sleep increases. It becomes difficult for the body to digest food. Appetite and food intake decrease. Liquids are preferred. Anorexia may be protective. And ketosis can diminish pain and increase the person's sense of well-being. 1 to 2 weeks prior to death, a host of physical changes begins, and the body begins to be unable to maintain itself. The days to hours prior to death, a sudden surge of energy brings about mental clarity and the desire to eat and talk with family members. However, as death approaches, patients tend to become dehydrated and have difficulty swallowing. So this decreases blood volume, and then in the final hours of life, they may become restless, agitated, and this might be a response to medication, liver failure, cerebral hypoxia, renal failure, stool impaction, distended bladder, emotional issues. Near the time of death, people are unexpectedly becoming more coherent and energized. Others become less communicative, quiet, withdrawn. Fatigue is common. So typically they don't need to eat at the end of life. That's a response that we do, thinking that they need to eat. And then the moments prior to death, the dying person doesn't respond to touch or sound, cannot be awakened, and there's short series of long spaced breaths before breathing ceases entirely and the heart stops beating. End of care, there's two words that really come to play, and that's palliative care and hospice care. So palliative care is symptom management, managing symptoms, signs and symptoms of death. It's more holistic comfort care. And then hospice care is where you actually enter hospice and you have 6 months or less to live. And their care, holistically caring for dying patients. So hospice has two key premises. The quality of life is important as the length of life, and those who are terminally ill should be allowed to face death with dignity and surrounded by the comfort of their homes and their family. Hospice does include nursing care, but also hospital care if needed. More times than not, hospice is in their home. Palliative care is more on supporting the families and the caregiver, the continuity of care, the respect for human life, informed decision-making, emotional and spiritual concerns, and just symptom management, like I'm saying, pain, dyspnea, depression, just taking care of the symptoms, but it doesn't have to be at the end of life. So it could be a COPD patient, could be an asthma patient. It's more than just end of life. Legal and ethical concerns, advance directives, do not resuscitate orders, allow natural death orders, medical aid in dying, and palliative sedation. So medical aid in dying, the American Nurses Association actually came up with a standard of care for those states that MAID is legal. It permits a competent adult with a terminal disease to self-administer oral or enteral medication that may hasten death. So nurses are ethically prohibited from actually giving these meds, but must be knowledgeable about the arguments for and against, and know their own personal values for this. Advance directives are a group of instructions, oral or written, stating a person's wishes in case they're incapacitated or unable to make a decision on their own. And a power of attorney would be someone who is allowed to make those decisions when you cannot. DNR is literally just a order not to attempt resuscitation. So there are some legal and ethical considerations to be included in this. Would be assisted suicide, euthanasia, autopsy, and organ donation. So autopsy is removing the organs and examining the tissues to provide a cause of death, and it requires a permission from the next of kin except in those cases where it might be suspicious or unwitnessed death, then it's considered don't need permission. Euthanasia requires the deliberate ending of life. Active euthanasia is the direct action of an overdose of medication. Assisted suicide means making means available for the patient to end their own life. So again, a nurse needs to know how that they feel about this and what role they want to play in that. So assessment for terminally ill, knowledge base, history of loss, coping ability, support system, the meaning of the loss and the illness. Are they depressed or are they in grief? Having a full physical assessment, cultural and spiritual assessment, and then knowing that most grief is normal, it's not dysfunctional. And you can view loss and grieving as the problem or the etiology. Some planning that goes around grief resolution and coping. That's where most of our work comes from. And then grief work facilitation, counseling support, spiritual support, group support, anxiety reduction, and coping enhancement. So emotional support, relaxation therapy, and forgiveness facilitation. So the big thing for nursing is that you need to perfect your listening skills, encourage and accept expression of feelings, reassure that it's not wrong to feel anger, relief, or unacceptable feelings, respond to nonverbal cues with touch and eye contact, increase your self-awareness, and continue to communicate even in the case of coma. The patient's hearing is the last to go. Facilitating grief, especially with the families, having them express their feelings, recall memories, finding meaning, and bibliotherapy can also be helpful. So if they write their story. Helping families of dying patients, have family help with the care if able, encourage questions, provide follow-up for referrals, encourage a visit to the chapel or talk to clergy, anticipatory guidance, and acknowledging feelings of the family. You're exploring coping mechanisms, reminding family members and significant others to take care of themselves is all. Teach what to expect and provide reassurance. Ask directly if family wants to be present at the time of death. And at the moment of death, do not intrude. Just stand by. So, check in. Your 55-year-old patient was just informed that they have metastatic pancreatic cancer and 4 months to live. After the provider leave, they say to you, I don't want my family to know, but they have to know. Please don't tell them. Please tell me what to do. Help me. What's your best response? Think about therapeutic communication. I know this is difficult for you. Take time to think about it. You should get a second opinion before you alarm your family. Let me hold your hand to make you feel better, or tell me how you are feeling right now. Thought process. You don't really need to hurry to make this decision. I'm thinking you just want to keep them talking, so tell me how you're feeling would be probably the better situation. Dying person, meet their physiologic needs, meet their physiologic and psychological needs, addressing their spiritual needs, their cultural needs. So a lot a lot of therapeutic communication. Clicker check. The client of a dying cancer patient can no longer swallow. The son states to the nurse, "You must give Dad some water. He always drank lots of water." What would be your best response? "You sound very upset. Tell me more about your dad." "Your father is dying from cancer and water will not stop this process." "Research shows that withholding oral fluid decreases edema." Or I'll call the provider and get a prescription to insert a nasogastric tube for the water. What do you think you should do? The question is, what's really going to be best for the patient? If he can't swallow, why are we putting water down? It's really not in his best interest. So A, you sound very upset. Tell me more about your dad. Continues to get him talking. Then you can start talking about the real meaning of not being able to drink anymore and not swallowing anymore. All right, and then providing postmortem care, you're going to follow the agency policies and the cultural and spiritual preferences of those people. Emotional support immediately after death, grief education, and then help children deal with the loss. Know how to respond to those patients' family members. And in the loss of a patient, it is normal for you to also feel grief when your patient dies. You also need to make sure that you're taking care of yourself too. So Bob and Kim were walking with their 5-year-old twins when a driver lost control of his car and hit them. Both girls were rushed to the hospital where one was pronounced dead on arrival. The other twin suffered several broken bones and was listed in stable condition. She keeps asking for her sister. What factors should be considered in this scenario? And discuss how you would provide care to this family. So Bob and Kim are going to start feeling a lot of grief and remorse. One of the two children were able to make it. So different considering factors. Those kids tend to be very close to each other, knowing what you can and cannot say, talking to the parents about what they want you to say. Very, very important. You don't want to provide information that you were not told to let them know. And how would you provide care for this family? Caring for the remaining twin, also helping Bob and Kim with the burial plans for the other baby. Potentially getting this child out so that she can go to the funeral. So lots of stuff in there.